Hi everybody, welcome to our video on scrotal disorders. Let's start by talking about testicular torsion. In this disorder, the testicle rotates in the scrotum, and when it rotates, it can twist the spermatic cord, and because the spermatic cord carries blood vessels, this can lead to vascular compromise of the blood vessels going to and from the testicles. Let's start by reviewing the structures in the spermatic cord. So the spermatic cord forms at the deep inguinal ring and travels through the inguinal canal and enters the scrotum through the superficial inguinal ring and ends at the testes. And inside the cord, you can find arteries, veins, and also the ductus deferens. And I talk about the spermatic cord in the GI video on hernias because defects in the inguinal ring can lead to certain types of inguinal hernias. This is a drawing from the web just showing you how the spermatic cord here carries lots of blood vessels and other structures going to and from the abdomen. In the scrotum is a structure called the scrotal ligament, which secures each testis to the scrotum and limits movement of the scrotum. If this ligament is abnormal or stretched or floppy, that can lead to torsion because it can allow the testes to twist. To understand torsion, you've got to imagine this spermatic cord connecting to the testes, and then imagine that the spermatic cord begins to twist and it becomes knotted up. This will lead to compression of structures in the spermatic cord, and the first structures to be affected will be the veins because they have very thin walls. So when torsion occurs, there's compression of thin-walled veins and loss of venous outflow from the testicles. There's continued inflow, however, usually through the arteries because these are thick-walled structures. This means that the testicle will become engorged and it will develop what's known as hemorrhagic infarction. This is a picture of an engorged testicle, as can be seen in a case of testicular torsion. There are two subtypes of torsion. The first type is the neonatal form. This is the more rare form of torsion. This occurs in newborn babies during the first 30 days after birth, and this happens because the testes of the male baby have not yet become attached to the scrotum. The more common type is the adult form, which happens in boys 12 to 18 years of age. And the reason it happens in this age group is because these boys are going through puberty and their testes are growing in size, and that sets them up, if they have the right anatomy, to develop torsion. These boys who develop this problem usually have an anatomic defect where the testicle is not attached to the scrotum. The defect they most commonly have is called a bell-clapper deformity. That's where a structure called the tunica vaginalis covers the spermatic cord so it cannot attach to the wall of the scrotum. This leads to increased mobility of the testicle in the scrotum. If you've ever seen a bell in a tower, there is a ball that bangs against the walls of a metal structure surrounding the ball, and that metal structure surrounding the ball is called a bell clapper. So to understand a bell clapper deformity, you need to understand that normally the spermatic cord attaches to the testicle, and it's covered by a structure called the tunica vaginalis. But normally this structure just covers some of the testicle, not the entire thing. It leaves part of it uncovered. In the case of a bell clapper deformity, what you have is a very large tunica vaginalis. It covers the entire testicle and often even part of the spermatic cord. This prevents the testicle from attaching to the wall of the scrotum, which is out here. It also allows the testicle to twist inside of the tunica vaginalis, and that's why it's called a bell clapper deformity, because the testicle acts like the bell of a bell in a tower, and the tunica vaginalis acts like the bell clapper. But the point is, because the tunica vaginalis is too large and covers too much of the testicle and even some of the spermatic cord, it prevents attachment to the scrotum, and that sets the patient up for a possible torsion. The clinical features of testicular torsion are a painful, swollen testicle. That's because, as we described before, there is hemorrhagic infarction, and the testicle has become swollen with blood that cannot exit the scrotum because of vascular compromise. Another classic clinical feature you should know for step 1 of your boards is absence of the cremaster reflex. So to invoke the cremaster reflex, you stroke the inner thigh, and a normal response is contraction of the cremaster muscle, which will pull the ipsilateral scrotum and testis up. So on the same side as the thigh that you stroke, the scrotum and testis will pull up. This will be absent or missing in cases of testicular torsion. Testicular torsion needs to be treated right away, or it can lead to infertility and loss of the testicle. The treatment is usually surgical. First, the testicle will undergo detorsion. This is where you untwist the spermatic cord. This can sometimes be done manually at the bedside, although it's often done surgically in the operating room after opening up the scrotum. Next, the testicle needs to be fixed to the scrotum. This surgery is called an orchiopexy. And then finally, if the testicle is non-viable, it can be removed. And a very high-yield thing for you to know about this condition is that you must treat the contralateral testis. Remember that boys who develop this usually have an anatomic defect, and if it's present in one testicle, it's likely to be present in the other. So you treat the testicle that has the torsion, and you also secure the other testicle to the scrotum via an orchiopexy so that that testicle will not later develop a torsion as well. Next, let's talk about a varicocele. This is a problem where there is a dilatation of the veins in the testicle, specifically the pampiniform plexus of the spermatic veins. If you look at this drawing on the screen here, the veins in the scrotum form this web called the pampiniform plexus. If all or a portion of that web becomes dilated, that is what's known as a varicocele. A varicocele is caused by obstruction to the outflow of venous blood from the testicle, and it's more common on the left side, and it's very important that you understand this. This is a high-yield tie-in with anatomy for step 1 of your boards. The left spermatic vein drains to the left renal vein, which then crosses the midline to connect to the IVC. So there's a very long course that venous blood must travel from the left testicle to get to the IVC. In particular, the left renal vein that crosses the midline can become compressed between the aorta and the superior mesenteric artery. This is called the nutcracker effect. This can lead to high pressure behind the compression, and this can set up for a varicocele on the left side. In contrast, the right testicle has a vein that drains directly into the IVC, and therefore a right-sided varicocele is much less common. To understand this, let's imagine that we've got the inferior vena cava on the right side of the body. The right testicle has venous drainage that connects directly to the IVC. On the left side, the testicle has drainage that connects to the left renal vein, which then crosses the midline to connect to the IVC. And when the left renal vein crosses the midline, it can become compressed right here between the aorta and the superior mesenteric artery. This can lead to a buildup of blood flow and pressure behind the compression, and that can set up for a varicocele on the left side. In addition, you should be aware that varicoceles are associated with renal cell carcinoma. This is because renal cell cancer can invade the renal veins and cause an obstruction to flow. This can happen on either the left or the right. However, because varicoceles are so uncommon on the right side, when one does occur, one of the things you need to consider is that there may be a renal cell carcinoma present that is obstructing the venous drainage on the right side. Varicoceles can cause symptoms of scrotal pain and swelling. The dilated nest of veins is often described as feeling like a bag of worms. This is a classic description of a varicocele in the scrotum. Shown at the top right side of the screen is a picture of a man with a left-sided varicocele. You can see that the scrotum is swollen on the left side. There are some physiologic maneuvers which will increase the amount of swelling. If the man performs the Valsalva maneuver, which is where the man bears down like he's trying to have a bowel movement, this will increase the pressure in the abdomen and block the outflow of venous drainage from the testicle, so this will lead to more swelling. In addition, if the man stands, gravity will pull blood downward, and that will also lead to more swelling of the varicocele. You can make the diagnosis by ultrasound. This is a picture of one in the bottom right side of the screen here. On the right side of the picture, you can see all these black spaces. Those are the dilated venous plexus. And then finally, one thing you need to be aware of is that varicoceles can cause infertility. The backup of blood flow can raise the temperature in the scrotum, and this can cause decreased sperm production. In addition, the varicocele can lead to poor blood flow, and this can also decrease sperm production. And some men have no symptoms and aren't aware they have a varicocele. So one of the things you have to consider when working a couple up for infertility is that the man could have an occult varicocele, and for this reason, an ultrasound of the scrotum is often performed. Varicocele can be treated with surgery. It's called a varicocelectomy. This is where the surgeon isolates the dilated and abnormal veins and redirects blood flow to the normal veins in the scrotum. It can also be treated with an embolization procedure. This is usually done by an interventional radiologist. A catheter is inserted into the dilated or abnormal veins, and a coil or sclerosant is used to clot off those veins so that no more blood flows into them, and then the blood will be directed to the normal venous structures. Next, let's talk about a hydrocele. This is an accumulation of fluid in the tunica vaginalis. We talked about the tunica vaginalis earlier when we described the bell clapper deformity that can lead to testicular torsion. The tunica vaginalis is a small fluid-filled sac that attaches to the testicle, and when it accumulates fluid, that is called a hydrocele, and that will lead to swelling of the scrotum. And importantly, when you put a flashlight up to the scrotal swelling in a hydrocele will transilluminate, meaning it will fill with light, and this differentiates it from a solid mass or tumor, which is also in the differential diagnosis for scrotal swelling. There are two forms of a hydrocele, the newborn form and the adult form, and these are very easy to understand if we review a little bit of embryology and talk about how the tunica vaginalis forms. During development, the testis descends into the abdomen, and it pulls with it an outpouching of the peritoneum, which is called the processus vaginalis. This outpouching will eventually obliterate, and all that will remain is a little bit of covering over the testicle. This is called the tunica vaginalis. And if you understand this embryology, then it's very easy to understand hydroceles. A hydrocele occurs when something causes this tunica vaginalis to become filled with fluid. So the newborn form of hydrocele is caused by incomplete closure of the processus vaginalis. This should be very easy to understand after what we just discussed in terms of embryology. This is called a communicating hydrocele because the scrotum communicates with the abdomen and peritoneal fluid can collect in the tunica vaginalis. This form of hydrocele usually resolves spontaneously by 1 year of age, at which point in time the processus vaginalis should close. And just an aside here, but another problem that can happen with incomplete closure of the processus vaginalis is that men can develop an indirect inguinal hernia, and I talk about that in more detail in the GI video on inguinal hernias. Now, in the adult form of hydrocele, there's no longer a processus vaginalis. It is closed off, so there's no communication between the scrotum and the abdomen. So hydroceles that occur in this setting are called non-communicating hydroceles. They are often idiopathic. They may occur secondary to infection or torsion or trauma, or something that leads to swelling of that tunica vaginalis in the scrotum. Sometimes they can even become bloody, and these are called hematoceles. But the point here is that these are differentiated from the newborn form in that there is no longer a processus vaginalis, so there has to be some direct insult to the tunica vaginalis to cause it to swell. Moving on, let's talk about a spermatocele. This is a large cyst on the epididymis. They usually occur at the head or top of the epididymis. If you look at this picture on the bottom right side of the screen here, the structure labeled A is the epididymis, and at the head of that structure is where cysts can form, and when they do form, they're called spermatoceles. These are usually asymptomatic, but they can be detected on physical exam as a mass at the top of the testicle that is separate from the testes, just like the epididymis. And the concern here is that the mass could represent a malignancy, and that's why they're worrisome, even though they're asymptomatic. Usually you can make the diagnosis with ultrasound. This is a spermatocele shown at the top right side of the screen here. The testes is this gray part right here. The spermatocele is the black circle on top of it. Spermatoceles are filled with fluid, so they're usually black by ultrasound, and they have a very different appearance from malignancies. Next, let's talk about cryptorchidism, which means hidden testes. This problem is usually caused by undescended testes. In development, the testicles descend from the abdomen into the scrotum. If they get stuck in the abdominal cavity or the inguinal canal, then there will be no testes in the scrotum, and that's called cryptorchidism. And it can be unilateral, meaning only one testicle is missing from the scrotum, or it can be bilateral. So in cryptorchidism, the testes aren't normally positioned in the scrotum, but usually they cause no symptoms. So a reasonable question to ask is, what's the big deal? Why not just leave the testicles in the abdomen or the inguinal canal? Well, it turns out there are a couple of complications of cryptorchidism, and some of these appear to get better if the testes are normally positioned in the scrotum. So first of all, cryptorchidism can lead to low sperm counts. When the testes are in the inguinal canal or the abdomen, the temperature in the testicles is higher than normal, and the higher temperature has effects on Sertoli cells that lead to low sperm counts. So untreated cryptorchidism can lead to infertility in a male. In addition, any male with cryptorchidism has a higher risk of germ cell tumors, especially seminomas. It's very high yield, remember this. And it appears that if you pull the testes down into the scrotum surgically, this lowers the risk. And then finally, because in cryptorchidism the testes do not descend normally into the scrotum, this leads to abnormalities of the spermatic cord and the inguinal canal. So cryptorchidism is associated with inguinal hernias. It's also associated with testicular torsion because the testicles aren't normally attached to the scrotum. So for all these reasons on this slide here, when cryptorchidism is detected, it's usually surgically corrected so that the testes will be normally positioned, so that torsion can occur, so that sperm counts will normalize, and so that hopefully the risk of germ cell tumors will go down. Cryptorchidism is usually detected at birth when the scrotum is examined and one or both testes are missing. The testes may descend on their own in some cases. This will usually happen by 6 months of age. If the testes don't descend on their own, or if they're thought to be unlikely to descend on their own because they're very high up in the abdomen, then a surgery can be done called an orchiopexy. This is the same surgery we talked about earlier for treatment of testicular torsion. It involves securing the testes to the wall of the scrotum. So the surgeon will pull the testes down and place them in the scrotum and secure them to the wall of the scrotum. Then the child should grow up with the testicles in the scrotum, and sperm counts will usually become normal later in life. And that concludes our video on scrotal disorders.